All right. Well, welcome
Okay.
to the first episode of Gyno Gurus, everyone. Yeah, really today we're just going to kind of be introducing ourselves briefly and then kind of getting into our topic of discussion for the day. So, Dr. Mandel, I'll kind of let you introduce yourself and we'll take it from there.
Okay. And well, first I want to thank Alex and Logan. They've been invaluable in this project, and it wouldn't happen without them for sure. Um, so I am a gynecologist, have been in practice for longer than I'd like to admit, 38 years. And I've had an interest in metabolic health for many, many years, and often use natural approaches to it. Not always. Sometimes medications are appropriate. Um, and one of the um, major metabolic issues of our time is insulin resistance. And
Yeah.
Alex?
So I think what's interesting and what's cool is that, with your almost 40 years of experience, you've lived through a lot of different seasons of just medical literature and kind of the development of medicine. And I think what's really neat and what I really liked when I met you is that you're always constantly evolving and like looking for new ways to like improve the lives of your patients and, the most holistic way possible. And of course, that does include medications, but it also includes supplements and lifestyle. So that was something that really just drew me to want to kind of practice like you and made me really look up to you. So I guess that kind of goes into myself and how we met. So my name is Alex. I'm a women's health NP. I'm initially from Oklahoma. So if you hear a Southern accent, that is why. It comes out occasionally, but not too often. So the reason why we actually ended up in the great state of New Jersey was because of this gentleman right here. Whenever I was in my clinical rotations at Vanderbilt, I was looking for a preceptor, and through the grapevine, got connected with Dr. Mandel. And then after I finished my clinical rotations, I begged him to hire me, and he did. So now we have been officially working together for about 6 months, and it's just been really nice to share interest and just how we approach treatment and getting to learn from him and be mentored by him has been very special. So I'm very, very fortunate. So yeah, and just as a disclaimer, this is not medical advice. If you have concerns, reach out to your local healthcare provider for further evaluation. This is just for education and empowering you with knowledge to better understand your health. So let's go ahead and get
Okay,
started.
let's dive into it.
Yes.
So the biggest metabolic problem is called insulin resistance. And it's a term that's a lot of people talk about, and it's not always easy to define. And insulin, first, let's talk about what insulin is, and then we'll get back to what insulin resistance means. Insulin is a hormone that's produced by the beta cells in the pancreas. And for those of you who are interested in anatomy, the pancreas is like kind of a triangular shaped organ in your abdomen, and it does two things. Uh, Sorry.
Popular man.
So it does two things. It has what's called an exocrine function, and exocrine means that it puts out uh, a substance that is not in the bloodstream, and it goes into the intestines. In other words, digestive enzymes. Okay. And that's not really what we're talking about when we talk about pancreatic function in the scope of insulin resistance. Uh, then within the pancreas itself are these little collections of cells called the islets of Langerhans. Okay. And actually, I think Langerhans was a medical student when he found them. So very, very interesting. That was many, many moons ago. Um, and so insulin is a small peptide hormone. Shut this ringer off. Okay, we're off, hopefully. And so it's a small peptide hormone, which is a collection of like the peptides are made from amino acids. Okay. And insulin I think of really as a storage hormone. So when when somebody eats something and they absorb glucose, okay, glucose needs to be processed in our body, and insulin is stimulates the storage of glucose. Um, if your glucose gets to be too high, it can lead to becoming very ill or death, and that would be an example of that would be what people might be familiar with. It's called type 1 diabetes or juvenile diabetes. And when your insulin gets really high, your body, uh, as it's trying to utilize it, it goes into sort of overdrive and starts metabolizing it into ketones. And ketones are somewhat acidic. And then you can get what's called ketoacidosis. And that will cause your blood pH to drop. And if your blood pH drops too low, you will start to go into a coma and then eventually death. So, keeping your blood glucose within a relatively tight range is important. And
And what would you recommend those ranges? Like, what was an
so,
optimal range for
so
glucose?
too high an insulin level would certainly, well, too high relative is a relative thing. So too high for the short term would be maybe over 250, 300, where you
Mhm,
start to get into those problems with ketoacidosis. But too low, sorry, too high long term is really probably, well, you have to look at glucose, whether it's fasting or
mhm,
after eating and how long after eating. So we're going to talk about fasting levels. That's what I've been referring to as
mhm,
fasting levels. So you're fasting fasting glucose, I like to see below 85. Now,
mhm,
labs define normal as below 100,
mhm,
but there's a difference between normal and optimal. So, normal is a statistical term, which means that 95% of the population falls into that range. Okay. But that doesn't mean it's an optimal level. And then, so with my patients, when I'm looking at a glucose level, I'm really hoping that it's 85 or below.
mhm,
Between 85 and 100 is still in the normal range, and probably that should be addressed more with like lifestyle
mhm,
and possibly supplements than medication for sure. And then when you get to between 100 and 120, 125, I think they use 125 is and above is defined as diabetes. So if you have a level of fasting blood sugar of above 125, then we would call you diabetic. And that I think just about any physician would be obligated to treat.
mhm. Yeah. So you're talking, about, like, optimal glucose levels and stuff like that. I think a lot of people are really familiar with having their glucose tested, their hemoglobin A1C tested, but what about actually testing our fasting insulin and potentially doing, like, an OGTT, which is an oral glucose tolerance test with insulin response? Like, do you think that that's valuable
Oh,
to add to
eh,
labs and why?
yes, it's valuable. So, so this is leading towards insulin resistance. So as your glucose level goes up, your body produces more insulin. And as your insulin levels rise, okay, it will lower your blood glucose.
Mhm,
But the levels get higher and higher, and it's almost like the organs, certain organs, become less and less responsive. It's sort of like if you go to um, a noisy environment, after a while, the noise just blends into a low level din, and you sort of just block it out.
mhm,
And that is what basically happens in a very simplistic way
mhm.
in the different organs.
Right.
So instead of, um, so higher and higher levels of insulin will lower the glucose, but eventually the body can't keep up with it. And then that's when diabetes develops. So when you're measuring glucose, even though it's in the normal range, it doesn't mean your insulin levels are optimal.
Optimal, yeah.
And it's it's the first sign of rising
Mhm.
insulin level of having a problem.
Right. Yeah. And I think what's interesting too, because I mean, even in my short career, I've had patients come to me who, trouble losing weight, you have cravings, and then they say, well, my glucose levels were normal, according to my PCP, and my hemoglobin A1C was normal. And then I normally ask them, well, did you have your insulin tested? And the answer 99% of the time has been no. So I think the value of testing insulin is that it does give you some very important data because it really shows us, is your pancreas working really hard to keep these glucose levels in check? Or, is it low and your glucose is low and everything is working as it should? So, yes, testing insulin, fasting insulin specifically, I found a lot of value in my practice. And I know you have as well because I followed
Yes,
you for
I
8 months and I know how you work. So yeah, we definitely are very big into testing that and with, good cause. And I think also a good thing to kind of maybe debunk a myth here is that insulin resistance does not only occur in people who are overweight, or, it can occur in thin people. I have had patients myself who have been on the thinner side, and, athletic, and they'll still have insulin levels that are above what we call optimal. And again, that is like the beginning, first stages of metabolic disease. So, it's important to monitor that, catch it early, be able to treat it with lifestyle supplements, and monitor it. So, yeah.
yes, and actually, I'll add the utility of a oral glucose tolerance test with insulin levels done at the same time. And an oral glucose tolerance test, you're given a certain fixed amount of glucose
Mhm.
when you're fasting. Your blood is drawn when you're fasting, and it's measured for glucose traditionally, but a lot of clinicians also get insulin with it.
Mhm.
And so you see what your fasting level is, and then to a fixed amount of glucose over a course of time, it could be a half an hour, 1 hour, 2 hour, 3 hour, 4 hour, and even 5 hours, depends on what the clinician is ordering.
Mhm.
But you can follow how your body responds to that glucose and in not only how high your glucose is going, but how much insulin you require to lower
Mhm.
your glucose. And so it gives you a more dynamic test.
Mhm.
And I'm going to contrast that to a hemoglobin A1C. So hemoglobin A1C has really taken over. Years ago, we used to, before hemoglobin A1Cs, we used to do a lot of glucose tolerance tests,
Mhm.
but not with insulin way back then.
Yeah.
Um, so we just would just follow the glucose level. But the hemoglobin A1C is a test that was developed, and it measures the amount of glycosylated hemoglobin. So when your hemoglobin is, I'm sorry, when your glucose is high, it will stick to different proteins and can actually interfere with the function of proteins. But they found that hemoglobin, which is a protein in your red blood cells that carries oxygen, the glucose sticks to it. And as it sticks to it, it stays there forever. Once it happens, it's a one-way street. Doesn't go back, it doesn't reverse.
Mhm.
But red blood cells have a 90-day life span. So if you measure a hemoglobin A1C, you get a reflection of the glucose control over the last 90 days. And hemoglobin A1Cs are very useful, and they're much easier to administer than glucose tolerance tests.
Yeah.
And that's why
No one
they were
wants to be at the lab for 4 hours, but it
e-
does give you some really good insight.
exactly
Yeah.
right. Um, And, so but there are certain conditions that could cause your hemoglobin A1C to be wrong. And for example, if your red blood cells have a short lifespan, like in certain medical conditions, like, well, I'll use hemolytic anemias, for example, or if somebody bleeds a lot, maybe with her period, for example, and so there's more turnover of those red
Mhm.
cells. Maybe the real lifespan of those red cells isn't really 90 days. So a hemoglobin A1C that is normal could be wrong
Right, which
I
that makes sense.
in
Yeah,
in the
yeah,
glucose control.
sure.
Yeah,
Yeah.
and conversely, a hemoglobin A1C that's elevated in somebody who maybe has a longer lifespan of their cells could be artificially elevated, although that's not that common. I think it's the other way around that's more
Mhm.
common,
Yeah.
but it's important to keep in mind, um, you know, that aspect of it,
Mhm. Yeah,
and hemoglobin A1C, for example, tend to be a little less, accurate during pregnancy, so
sure.
they're less used in pregnancy
Yeah.
for that.
Yeah. So all this to say, I mean, we have talked about, reasons why this is so important.
Yeah.
Of course, in the setting of gynecology, which is where we both work, mainly where do we see metabolic dysfunction? It's going to be in our patients with PCOS. But, we've talked about this before, kind of the long-term health sequelae of untreated insulin resistance is like, what does that lead to? We've talked about it, it leads to things like cardiovascular disease, dementia, blindness, fatty liver, hypertension, everything. I mean, like basically anything you can think of, it's like you could pretty much
Yeah, a
guess
lot
that
of
insulin resistance
just
can play
about
a
all
role.
your chronic conditions and
Yeah.
even cancer. Cancer
Mhm.
rates are higher
Yes.
in, people who have poor glucose control,
Mhm.
and that's been very well established. Um, so I wanna go back to insulin for a moment
Mhm.
because I think I didn't explain something very, clearly. So insulin lowers glucose, but how does it do it? Why does insulin lower glucose? So insulin, I think I said early on, is just I think of it as sort of storage hormone.
Mhm.
It's telling your body to store that glucose. So if you're not burning it, okay,
You're
which
storing it.
you're storing it,
Yeah.
okay, and with energy metabolism, um, you basically have two options: you burn it or store it. I will say there is an exception metabolically speaking. The exception is somebody who's like in a ketogenic state. A lot of ketones, you can actually excrete ketones.
Mhm.
So ketones can be excreted in the urine, and also you can sweat them out and you can exhale them.
Mhm.
So if you like somebody on a ketogenic diet may have like kind of a fruity breath,
Yeah.
and that's the ketones. So but unless you're in ketosis, you only have two options with your energy: burn them or store them. So insulin will stimulate the storage of the glucose unless you're burning it. So just as an example, most people eat dinner and they become sedentary and they're not burning those calories, so they're going to store them. If you went out and did some exercise or walking or housework or whatever, you would probably gain less weight because you're burning those calories and keeping your glucose lower by burning them off also lowers your insulin level because the
Mhm.
insulin responds to your glucose level. So it's a cycle that um, regulates your glucose level.
Right.
And like I tell patients all the time, and Alex have heard me say this, during the day, you eat something, you're active, you're moving, you're burning a lot of those calories off.
Yeah.
At night, you become sedentary, and now you're storing them. So um, that's one of the reasons why eating less in the evening, even if you eat the same number of calories during the day, having less in the evening, more early in the day,
Yeah.
will lead to less weight gain.
Less weight gain. Yeah. Yeah, you do talk
Yeah.
about that a lot. And I feel like I could recite some of Dr. Mandel's office visits just from listening to him so many times.
Well,
But one area that I also did want to focus on was just basically like the prevalence of this because we talk about it all the time, but like really it's just like, okay, like how common actually is insulin resistance? So I actually looked up some, studies last night, some statistics. And honestly, it was scary, actually. So 44%, according to a large scale study that I was reading, 44% of adults 18 to 40 years old, or it might have been 40%. Yeah, it was 40% of adults, same thing.
yeah.
18 to 44 had insulin resistance. And that percentage just increases with age. And then another thing that I also thought was really interesting was that in postmenopausal women, there was a sharp increase in insulin resistance, and, struggling with glucose metabolism. So I feel like a question for you that I would have personally is, why do we think, especially in menopause, like, do we think that this is something that's just related to age? Because we obviously know as we age, things kind of slow down, get a little bit more sluggish. But is there, like, to your knowledge, a direct relation to menopause in terms of hormonal, fluctuations and balances leading potentially to an increased predisposition to insulin resistance and kind of the health conditions that go along with that, if that makes sense?
Um, so if you look at both men and women, okay, to a little bit of a contrast.
Mhm.
So men don't go through menopause. Their
Right.
their hormonal change is more gradual,
Yeah.
but men get heavier as they get older
Right.
too. But it is true, a lot of women do tend to gain weight after menopause, and there's certainly um, hormonal influences that are going on there. Um, there's I haven't seen any really well done study. Doesn't mean it's not out there. I can't,
Mhm.
nobody can read everything.
Yeah.
And
Not even you.
and maybe when I get a chance this weekend, I might even look that up a little bit.
Yeah.
But menopause does tend to cause weight gain, and the more you weigh, the more insulin resistance you're going to have, and that sort of magnifies this effect.
Mhm.
And so to answer your question is yes, but I couldn't quote you a study,
Mhm.
but I clinically believe that it's true.
Right, right. So I guess like from that perspective, because we talk about treating, especially trying to catch these things early, treating it with lifestyle supplement and stuff like that. Do you treat those people the same as you would treat, like, I guess, a 15-year-old who has PCOS, like with recommending supplements, exercise, stuff like that? Or I'm just curious, or would you take a more like aggressive approach and go straight to medication for
Uh,
someone like that?
it all depends on degree.
Yeah.
So I try to, well, I never recommend medication in lieu of lifestyle. Lifestyle is the
Yeah.
linchpin. Um, if you, it, what's very interesting, if we went back 150 years, most doctors might see one or two patients in their lives with diabetes.
Yeah, I remember
Okay.
you saying that.
Yeah.
That's so
It was a
interesting.
rare
Yeah.
condition. And now it's so common. Everybody knows somebody with diabetes.
Yeah.
And so it has a lot to do with lifestyle.
Yeah.
And so the first thing is, like I talked about um, early on, is not only when you eat, what you eat. Um, processed foods are not good for glucose control or insulin levels. It's almost like if it has a barcode, it's probably not good for your insulin. Natural foods are much better for our bodies, and that's what we've been designed, if you would, to have. So
Yeah.
we don't process a lot of these foods, and also high levels of fructose,
Mhm.
which at some point in the future we'll get into. We could go
We
down
could do a
that.
3-hour
Yeah,
video
that
over
would yeah,
fructose.
that's a
Yeah.
whole nother issue. But also when we look at the when I look at a young person, okay, like I'll see some um, young women, 18, early 20s,
Mhm.
and they come in and they're overweight. They have very, very irregular periods or no period at all.
Mm.
They have PCOS. I look at that person and I think here is an opportunity to really impact someone's life if we can get them on a better metabolic path,
Pathway, yeah.
because not addressing it will lead to having all the sequela of of you know metabolic syndrome, which like we talked, like Alex, you mentioned
Yeah,
before,
heart disease,
the
diabetes, everything.
yeah, everything.
Yeah, and like you said, it can be younger than that. I think, the youngest person that I probably seen in practice has been 15,
Oh yeah.
and, having a elevated insulin level, it's with no other symptoms, and then it's just like, "Oh, but the reference range is normal," and it's like, that's why it's so important to understand, normal versus optimal. That was something that I didn't even know prior to actually, like, working with you and being mentored by you, because I think if I wouldn't have been, I would've been like, "Oh, yeah, like,
Uh,
it's within the normal range, so it's normal,"
exactly. So many
but
people look at
yeah.
labs and go, "Oh,
Oh,
they're
yeah,
normal,"
yeah, yeah.
but that's
So
not optimal.
right, and it's like, especially for those young girls, with the PCOS who do have, like, the beginning stages of metabolic, dysfunction. I mean, it's a life-changing thing, catching that early and treating it. I mean, at least acknowledging that it's there, I think is what also is so important.
No
So
doubt.
yeah, so that kind of leads us to, like, what we're gonna be talking about in some future videos, but basically, like, is this something that is reversible? Like, you know what I'm saying? Or is this something that was more just we manage it because, as we know, there is a genetic predisposition to things like insulin resistance, which we could also talk about that for a long time too, which we don't have time for in this episode. But basically, like, what can we do? Like, is it reversible, or like, is this something that you just have to live with? And the answer is, like, it is reversible.
No doubt about it.
And yeah, but the key to it is early detection, testing it, and then also being aware of what the normal versus optimal is, and really looking to get yourself into the optimal ranges, and not just settling and being complacent with a reference range because it's
Right.
not in red.
Like, for example, a normal fasting
Yeah,
insulin in virtually all labs is
up to
less than 25.
25.
Yeah.
Yeah.
Yeah, and
If
I
we see your
yeah,
insulin of 25 or
yeah,
other higher than
yeah,
20, then
yeah,
we have a
yeah.
problem.
Even above 10, I
Yeah.
it's really not
If
normal.
we really, really
I
wanna
should
be
say not
picky,
optimal.
we can say
Yeah,
5, I'm just
yeah,
kidding,
yeah,
but
5 would
5
be
is,
really optimal.
yeah, really optimal. So we have really
Yeah,
optimal,
yeah,
and then reference range of the lab.
yeah,
But yeah.
exactly.
So
So
kind of to summarize, I mean, I think that the take home message really for this episode, I mean, we talked about a lot. We got kind of into the weeds with, like, the pathophysiology, which I know can be kind of difficult to understand, especially if you're not, you know, super deep into science. But really it's knowing what is normal versus optimal, knowing that these are things that, even though insulin is not routinely tested, you can ask for it. It needs to be looked at because it's not the same as testing your glucose or your hemoglobin A1C. Testing insulin all by itself has significant value, and you just being able to detect early stages or signs of metabolic dysfunction. That way, you can treat it with lifestyle supplements, before we get to things like diabetes, PCOS, and all of that stuff. So, all that to say, I think that
yeah,
that's pretty much
yeah,
covers what we wanted to
yeah.
talk about in the first episode. We took, how long did it take us to actually
Oh,
start this? It was like 6 months. And
that's right,
yeah,
and
we
yeah,
baffled back and forth
yeah.
what we were gonna talk about for our first topic, and I think that this is a good start just because it's so prevalent, and it's not really talked about a whole lot. I do feel like it's kind of up and coming. I feel like it's becoming more of a thing, like, talking about insulin resistance and, like, what
I
you can do
agree.
to treat it, but
People have, like, referred to metabolic syndrome,
yeah.
and, matter of fact, years ago, they used to say dysmetabolic syndrome,
Yeah.
which to me is probably
Yeah.
a better term, but, and just to explain metabolic syndrome, it's actually there's a definition, and it's, if I recall, is high blood pressure,
Yep.
um, low HDL cholesterol,
Mhm.
high triglycerides, and abdominal
Yeah,
ob
circumference.
ob
Mhm.
obesity.
Obesity,
And the
yeah.
abdominal obesity is reflecting what we call as visceral fat or fat in
Mhm.
your around your organs, and specifically fatty liver. But we will get into these things in more detail. Um, this episode today was really to introduce the concept of insulin resistance,
Mhm.
which is basically just your body can't has to produce more and more insulin to keep your glucose under control, and the more insulin that's produced, the more storage of energy is going to occur,
Mhm.
and so that's going to lead to becoming overweight and leads to the other metabolic problems,
Consequences that come
consequences
with
that
that.
come with
Yeah,
that.
yeah.
So,
So, All right,
Yeah,
guys.
so
Well, thank you so much
yeah,
for listening. We hope that you guys found this helpful and that you learned something today. So stay tuned for the following weeks for our follow up on lifestyle supplements
yeah.
and yeah,
Yes,
all
and
the other things. So thank you
we
guys so much.
yes, thank you all. Appreciate your time.